Hello, we are Marianne and Sarah, two nurses who love conversations that provide education and empower people to improve their health. We bring the global experts to you, keeping you up to date with the latest medical advancements in patient blood management. Listen as patients and doctors share their personal experiences and stories, unfiltered and honest.
Our vision is to raise awareness for blood health because the blood system connects to every vital organ. Your blood reflects the state of your health and gives insight on what's happening throughout your body. Understanding how to protect and improve your blood health is vitally important to your wellness journey. Stay connected to your blood health.
Hello, and welcome back to Let's Talk Patient Blood Management. And we're here today with Dr. Terry Gibbs. And Dr. Gibbs is a clinical assistant professor in the Department of OB/GYN at the University of Toledo College of Medicine and Life Sciences. He's an active member of the North American Menopause Society and the International Society for the Study of Women's Sexual Health and became an NAMS certified menopause practitioner in 2007. That's really cool. Dr. Gibbs is a colleague and friend of Sarah here. Sarah, why don't you tell us a little more about your friend?
Oh, gladly. I met Dr. Gibbs in 2017 when I was gifted with a career in bloodless medicine, and I was tasked to build a patient blood management program for our mutual healthcare organization. And one thing I can say about Dr. Gibbs is he is just as proud of his family as he is about his career. He's married with 3 children and has 4 grandchildren that he just adores. He opened the first menopause clinic here in Toledo, Ohio, and he started the Cancer Center Genetics Clinic for ProMedica Health System, which I did not know. Dr. Gibbs is on the board of directors for the Ohio Sexual Health Collaborative, for which he hosts a podcast as well called Sex Ed for Sex Med. Get that?
Yeah, so now I'm really curious. Dr. Gibbs, your experience seems to span the entire female lifespan, from pregnancy to menopause. What are we discussing today? Sexual health and anemia, or is that another episode?
Everything.
Or what are we going to talk? All right.
Everything.
Awesome. Yeah. So welcome.
Thank you.
Welcome.
Thanks
Thank
for
you
having
joining
me.
us
Appreciate
today.
it.
Awesome.
You know, Dr. Gibbs, when early on, when we started to build the patient blood management program, you were an early adopter of our consultative services. And I'm just wondering what convinced you that patient blood management in the OB/GYN sector was good for the patient and had a value for your patients?
It's an easy answer. When I was thinking about going into OB years ago, I was kind of talked to a woman that knew our family who was an obstetrician who actually delivered me and was a good friend of the family. And when I got to medical school, when I would come home for vacations, she would let me hang out with her and go do deliveries. And she was in Hammond, Indiana, just northwest Indiana. And there was a very large congregation of Jehovah's Witnesses in that area. And she was the one that all the Jehovah's Witnesses went to because she understood and was really good with, their feelings and what they needed to be safe in their beliefs. And she taught me that, this is cool. And so, from the get-go, I think people's desires with bloodless management, it just made sense. So that's how I got started.
Oh, that's so interesting.
And then when we decided to open that up, patient blood management to the broader population, it was probably a more natural thing for you because you were already so experienced with those who blood was not an option. And so it made sense for you then.
Yeah, it did, because, what we were doing with the Jehovah's Witness congregation and their beliefs, there was some scientific underpinning to it, obviously. And we just wanted to take those good principles and make them available to everybody. And I think it was very interesting when they came out with all of the studies from the ICUs showing that, people that got transfused didn't do as good as people who didn't get transfused. And all of a sudden everybody's thinking is like, hey, maybe we're not doing as good of a job as we thought.
So for pregnant women, I mean, that's, for a person that's going to choose to decline blood, it's obvious. It's so important for them to build up their hemoglobin and, focus on their anemia and get ready, because you could be the healthiest person and you're still going to have a little bit of hemorrhage when you deliver. They all do, right? Many of them do, even a little bit. So what about like pregnant women overall? Should all pregnant women be focused on their hemoglobin, what their blood count is, and focused on their iron? Is that for everybody?
Yes. And anemia in pregnancy is one of the most common things around. It's very common in women in the United States to just under 20% and almost 40% nationally or worldwide. And then when you look at the people who do have anemia, about 70 to 80% of them have iron deficiency anemia. So it's extremely common. It's extremely easy to treat, but it's extremely important because it really can have some very bad consequences. So the feeling by all of the American College of OBGYNs and all these groups is that this is a no-brainer. Yeah, I mean, everybody gets treated, everybody gets started, because the amount of iron people are walking around with, their storage, and what they're getting in their diet is not enough to carry them through their pregnancy and get them to delivery with a good blood supply. Because not only do you have mom's requirement, but you have a baby and a placenta. And so, yeah, the requirement does shoot up.
Yeah.
So when should a pregnant mom be, I guess, have her first evaluation or for anemia or iron deficiency?
In a perfect world, when they come in during their first trimester, they get their first, at least their first blood count then, and then they get put on an oral iron, and hopefully they are very compliant with that. And then they would get rechecked again at the beginning of the third trimester at 28 weeks. And if they're still anemic, then if they're anemic even early on, you want to do a blood workup and figure out why. There's many reasons for anemia, but like I said, 70, 80% of the anemia is going to be iron deficiency, and that's easy to check. You get a serum ferritin level.
Sure.
Okay. And so she comes in at her first trimester. So we're talking first 12 weeks of pregnancy. We find out that she's a little anemic, iron deficiency. How do you treat that?
Well, you start off with just the oral iron, and then you want to give iron, even if she's not anemic. You want to give iron because remember I said the amount of iron needed in the pregnancy is not sufficient. Just looking at a woman's storage, what she stores, and her diet will not be enough.
Gotcha.
So you want to supplement. I would use the word supplement instead of treat. I would supplement her with iron from the get-go because she's going to have a greater need for iron in the pregnancy.
And how much, I work with you in the OR and I see surgeries, and I've been generally very impressed with how much blood we don't lose in surgery. However, when we go into a C-section, it appears to be a little bit more bloody. And I know that that's not all blood. It's some of it is the,
Amniotic
fluid,
fluid.
the amniotic fluid that makes it look more intense. But what's the expected blood loss if during a delivery, C-section or vaginally?
It varies, anywhere from maybe 100 or so milligrams to 500 for a vaginal delivery. If it's over 500, that's considered more of a hemorrhage. It could be up to 1,000 cc's for a cesarean before you call it hemorrhage. So I mean, that's a very significant blood loss, and the body knows that that's coming, and so it kind of prepares. That's why the need is higher for iron, because it prepares the body for that loss. It's becoming, and I'll just interject this, but it's becoming a focus of research on anemia in the postpartum period for women, because of what you're talking about, that normal blood loss. If you're right on the edge and you have a normal blood loss and kicks you into anemia, there are lots of issues maternally with anemia in the postpartum that I think is very interesting, because it can just be, fatigue, but also there's an increase of 50% increase in depression in women who are anemic. And it's interesting because the American College of OBGYNs, their new president, they just had their big annual meeting this year. And the new president, her focus for the year is maternal mental health in pregnancy. So this is a big subject. And just this, blood loss has a big impact on this whole subject and this whole problem. So it's a big deal.
That's so, I've never heard that about the link to postpartum depression. And that's interesting because I don't know if we're hearing about it more often due to the internet, or it just seems so common with people, or maybe it's becoming more recognized, which is really a good thing.
There's some studies too, aren't there, about the developing fetus and the mom being anemic? So is there consequences to a developing fetus if mom stays in a iron deficient state?
Yeah, there is. The baby can have, growth issues. You have a restricted growth. That's very common in a real anemic mom. She can have the baby can come early. They have a premature delivery that shoots up. And I think the most important concerning thing to the fetus is if the mom is severely anemic going into delivery, you're much more likely to see a bad fetal tracing and the need for like an immediate cesarean and having baby in fetal distress in mothers who are severely anemic. And then if the mom's anemic, the baby is most likely going to be anemic itself. Makes sense. It's getting all of its iron from mom. And there's very clear studies now showing that there is what we call neurodevelopment. It's a big word for just, your development to think and act. And they're seeing much higher incidence of things like ADD, ADHD, and some of these thinking issues with these little people. And because of the development of the nerves and the need for iron that's just not there. So there's big impact in mom and the babies with this anemia. And it's so common. and it's so
Right.
easy to treat. Here's the thing on that. You start off with oral. It's the easiest, number one. But really, a very small amount of the iron you take gets absorbed on a daily basis.
Mm-hmm.
And I know we used to give like 2-3 iron pills a day, which made women so constipated, so sick. And now, everybody clearly states not a good idea. A smaller amount every other day is the wise thing, because the amount that's absorbed again is the same. And so you have less side effects, and just as good a result if you give a smaller dose every other day. Now, if they get to the third trimester and they're still anemic, I think it's very prudent to talk about the use of IV iron, because what it takes oral iron to do in 3 months takes IV iron, 2 weeks. And so,
Right.
in fact, in Europe, I was listening to somebody recently that said just in Europe, at 34 weeks, you get checked. And if you're anemic, boom, you get it. I mean, it's not a discussion. It's come on in for your iron. And this is really important.
Love that.
That I want people to know, because this was a surprise to me when we first started doing this. People are saying the cutoff for even in pregnancy for the hemoglobin, the measure of how much blood cells you got, was like 10.5, and I thought, oh man, I thought that's kind of high. Well, if you're pregnant and your hemoglobin, your measurement of anemia is 10.5, you are in the lowest 5% of people with, that lowest 5% of hemoglobin of otherwise healthy women, the lowest 5%. So it's, what seems like, hey, I'm not too bad. No. You are in the lowest 5%. You need to do something, because the need for iron really picks up again in the third trimester. And if you're behind what you have, it's going to really turn into an issue in the third trimester.
Right. IV iron, is that safe for the fetus and for the woman?
Yeah, it's very safe. The things that they're using today are very good, very safe. I mean, the one time you don't want to use them is if people have a hypersensitivity to the IV. Right. Number one. Number two, if they just have if they have known liver disease, you definitely want to get a specialist involved. Because you just douse them with a really large dose of iron that's dealt with in the liver, and that could be an issue. So, you don't want to just hit somebody if you know that they have liver disease. But that's it. I mean, it's really safe.
So, you're right. There's a lot of variety out there now, and there's the low molecular weight that's a little safer, doesn't have those reaction problems. And so as long as you're cautious about selecting the type and thinking about their overall history, it is a pretty safe option to help build them up for when they're ready for delivery. Is that what you're saying?
Yeah. In fact, like I said, this individual, this researcher said in Europe, it's like, if you're not at a certain level by 34 weeks, it's just like, come on in, you're getting it. And I think the important thing, a big take home message here is like, so what, does this really do good? Yes, it does. Yes, it does. And there's plenty of data now that shows us that if you jack up the hemoglobin and get it to where it's supposed to be, a lot of the problems with mothers, a lot of the problems with babies, I mean, drop off significantly.
Focusing seriously on this one issue can prevent so much, like you alluded to, the postpartum depression and the fatigue. And I mean, fatigue, women are already going to be fatigued enough. They don't need anemia adding to their fatigue.
Amen.
So yeah, it's really important to focus on this, and and especially for the development of the fetus too. Like, that's so important.
One thing I wanted to comment on is after the delivery, and I'd like to talk a little bit more about postpartum hemorrhage. But after the delivery, something that would happen in our relationship is sometimes you would call us and you would say, Sarah, I have this mom. She's 5.5 or she's 6, but she's not symptomatic. And you have a choice when you jack them up, right? Do you just fill their tank with a blood transfusion and send them home? Or do you build them up? And a lot of times you would say, no, let the blood management group work with you to get your anemia up, and we'll check you in a few weeks. So the choice to a physician to jack them up with a blood transfusion, send them home, or patient blood management, why did you choose or opt for patient blood management?
You always, whenever you treat anybody, there's always, you base it on risk versus benefit. There's always a risk versus benefit ratio, no matter what you do. And so when it comes to IV therapy, if they're stable, now if they're unstable, we're not going to talk about it. Get it in here as quick as we can. But if they're stable, you can sit and tell them, boy, the first couple of weeks are going to be really slow for you. But it's clearly a benefit to be able to do a treatment that just has so much less risk to the patient. You get the transfusion, and I know it can do things to the marrow. I'm not an expert in this area, but I'm aware of this stuff, that there's, it can suppress things. It impacts the immune system. It's not without its problems. And so, if I have another treatment that I can get the same endpoint in a reasonable period of time, I'm not talking 3 months, I'm talking a couple of weeks, that I can get to the same endpoint without exposing the patient to a lot of risk, just because I want to get it done. That's a clear choice. And so I think it's a discussion you need to have with patients and say, I can do this or this. My recommendation is that you do this because you're stable, you can get up and you can walk around. And I think one of the most, I remember so well, I had this interesting, because she was a young Black female, because Black females have tend to have a lower hemoglobin than the white people. And, why is that? We don't know. And at one time they wanted to treat it differently and have different parameters for the different ethnicities. And then we found out it's like, no, we're going to start treating people different. It's going to get all screwed up. So everybody gets the same treatment, but we know that Black females have a lower hemoglobin. And this young, she was 16, and she had some postpartum hemorrhage issues, and her hemoglobin was 5. And the normal, we look at 12. She was 5, but she could get up out of bed. She was moving slow, but she didn't get up and fall over or anything like that. So I had this discussion. I said, you're just such a good candidate for not rushing to blood, because everybody in the department said, let's type in crosser, get the blood in here. I said, let's talk. And so I told her the risk of taking the transfusion, the whole thing with HIV and all this stuff.
Yeah.
And she said, hell no. I'll take the IV iron any day. And we followed her up, and she did magnificently. Now, okay, she's young and healthy, but most, people who are pregnant, most are young and healthy. And I think it's a really
Right.
honest choice, especially when you have to have that conversation of, okay, these are the risks to taking blood, and to hear those and think, wow, I could take this and get really sick. I mean, maybe not, especially if there's an alternative that has none of that risk. It just takes a little bit longer to get where you want to be. It's a
And
no-brainer.
that's exactly why we need to get in there early and look at people and see what needs to be done and kind of like forecast in our mind what interventions will need to be made. Because sure, IV iron does take a little bit longer, not significant, but we don't want to get ourselves to the point where we're in that knee-jerk reaction and need to feel like we have to save this life right now.
Yeah, it's an evaluation that you just kind of, sometimes you take your own pulse first, but you want to not have, bad habits. Like, we always give blood at this point. Well, why? And
yeah.
So I think the more it's, it's just like everything else. It's just one of those education things. And I think that if the department you're in has an awareness and has some education about the benefits of just using IV iron to as opposed to just running for the blood, I think you're going to get some good results. There was actually an article that just came out in one of the last OBGYN journals that the gentleman took a look at just everybody in the postpartum. And, if they were anemic, boom, they just got hit with IV iron before they left. And that's not very much time. You gotta go in and check and say, okay, she needs it. Let's do it. And and they would go back and they would follow these women and compare the people that some people got treated, some people didn't get treated, and it was significant. And so the bottom line to the article was, you ought to be looking for these people postpartum, and just such an easy thing. You give them some iron, and then you have them back and you watch them. So it's just not a hard thing. It's not a risky thing. I think it will probably land better one day when we get cheaper, when the treatment becomes cheaper, because it can be expensive.
Yeah.
That's the only thing.
Yeah.
Well, and transfusing blood is high cost too. But yeah. So, I mean, the important thing is before you're pregnant, once you're diagnosed as pregnant, during the pregnancy and postpartum, we should always be thinking about identifying diagnosis, prevention of anemia, and how we can treat it and how much time we have to do so. Right.
Because hemorrhage is still a big discussion in the OBGYN sector, right? Not to scare people, but what are the percentages of, say, a hemorrhage being considered a hemorrhage after delivery?
Well, I mean, it's less than 5%. It's a small group of people that just get that. But there are risk factors. And one of the things that a lot of, especially what we call level 3 OB units today, is you assess somebody for the possibility of postpartum hemorrhage. There's risk factors, and you type all that in, and it kicks out a risk factor of this person having postpartum hemorrhage. And then what you do is there's, we're thinking about it, which is great. And then there's actually a hemorrhage cart that you put outside the door. And so you can snap your fingers, and, we have a number of different medications that we can very boom, boom, boom give to a patient to really manage the hemorrhage. So I think we're getting a lot better at recognizing it and then doing something about it right now.
Oh, that's so important too, because minimizing the blood loss
Yeah.
when you have hemorrhage, we could talk about that for a day.
Yeah. Amen.
And how to respond to that as a problem and not just react and just start grabbing bags of blood and transfusing. Yeah.
Right.
Yeah.
And now we move on to our sexual health after pregnancy and delivery, right? That's probably a podcast episode for yours.
It was.
But
it was. Yeah.
It was it.
Yeah.
I'll have to look back and see it.
It was, yeah.
But tell us a little bit about your podcast and how that came about, Sex Ed for Sex Med, because I can tell you that I am a listener and a follower, and I've learned so much about my changing body. So I'd love to learn a little bit more about what you're doing in the podcast sector.
Well, it all started with an interest in menopause. And back in 2002, I went to my first meeting and really became interested because women go through two hormonal events in their life that are major. One is puberty, and one is menopause. The pediatricians beautifully handle puberty, understand it, and can guide people through it. And everybody's kind of on the same boat there, but menopause is all over the map. And it was really interesting because when I remember when I got out and started practicing, and especially when newer people would come and join the department, I'd say, "Hey, how's it going?" They'd say, "Nobody ever taught me two things: how to run a practice and what to do about menopause." But I got involved with a group called the Ohio Sexual Health Collaborative, because these people were also very involved in menopause, but they wanted to do something with sexual health because people knew even less about sexual health and issues than they did about menopause. And it's really just like what we were talking about with the transfusion world. I mean, if you live to your 51 or in your 50s, menopause is 100% chance. It's 100% chance. You're going to go through it if you live long enough. There's about 50% of women will report having some kind of sexual issue. But it's bitterly complained about most often in the middle age when people are going through menopause. And so, and again, you try and get on the internet, and it's just like, it's way all over the place. It's just, everybody's got this, that, and the other. And so, I buy into the fact, it's good to kind of learn new things, and even if they're not proven, but I like to use what we call evidence-based information. Research was done. We found, wow, this is really a good idea. Just like we're talking about the transfusion. And so you want to learn and disseminate good something with a basis, a scientific basis to it, evidence-based.
Right.
So that's what this is about. And then we started the whole idea of this group was to be of aid to other practitioners in Ohio, and then to be a resource for patients.
I love how you put that about women have two major hormonal events in their life. That's a really good way of thinking about it.
We've found out through research, women don't want to ask because they don't want to embarrass the doc, or they don't want to feel like they might be ill-received. And then docs don't want to talk about it because they don't know anything. So,
so no one's bringing it up except Dr. Gibbs.
Let's talk about your sex life. So
the podcast is a great way for women to come to you and learn something and feel that connection and feel like they can get help if needed. And help them to think about things that they probably didn't even think about, other than, oh, this is going to be awful. Yeah. So good. Yeah. Awesome.
Well, thanks.
any parting message for our audience today? Anything you'd like for people to take away from our discussion on anemia in pregnancy or post-pregnancy or?
Well, I mean, it's now that you're informed. This is the important thing. Now that you're informed, bring it up. You got to bring it up. And it's
Love
like,
that.
hey, did we check
Yep.
this? How am I doing in there? What's my blood level? And what else can I do? And I think it's such a simple thing, but it's an important thing. It's just like, you fill your gas, or you fill your car with gas. It's just a little bit important to look at the, level of fuel on the dashboard sometimes, because if you don't, you're going to run out of fuel and your car's not going to go. And so it's one of those things.
Right.
It's like, this should be easy. And this should be done. It's like not paying attention to your dashboard while you're just driving. So I would say that. And then I think the other things, like especially in the world of menopause, just go to some of these links, because there's a lot of places out there where they tell you how to hook up with somebody that can give you good information.
Thanks for being so willing to join us today.
I love talking about this stuff.
Can't wait to talk to you again. Let's talk PBM.
Same.
We hope you enjoyed this conversation and found some takeaway or new thought that improves your health. We would love to hear from you. Feel free to reach out to us on our website if you'd like to see what we're up to. Our website is letstalkpbm.com. If you enjoy our conversations, please like and subscribe wherever you listen to podcasts and on our YouTube channel.
Special thanks to our guest and our producer, Delaney Coronado, and the entire production team for all of their expertise in content creation, technical abilities, and dedication to our message. We appreciate the experts who drive this medical movement forward, and our affiliate partnerships who support the work that we are doing. Until next time, stay connected to your blood health.